Good evening, everyone. Welcome again to one more Saturday evening where we'll be talking about the W3 webinar series, that is the 2.0, which we have been continuing from the past year. Basically, we'll be talking about that. Basically, W3's what, when, and why. It's a program, it's an initiative brought by the PCOS Society of India along with the USP. So to start ahead, we'll be looking at a small video from our president, Dr. Durusha, you are a role idol for everyone, and actually this who has initiated this big PCOS Society of India.
Hi, I'm Dr. Durusha, the founder president of the PCOS Society of India. The society is of multidisciplinary experts in the field of gynecology, dermatology, endocrinology, and all the allied specialists who look after PCOS women. We all are focused on creating awareness on PCOS, both amongst doctors and updating their knowledge. And we are also wanting to create the awareness amongst women at large for them to understand what they are having and what their problem is. In short, our organization is consisting of experts both from India, and we also have members from outside the country. It's important for all of you to be with us and join us in our endeavor to upgrade our knowledge in this field and reach out to our patients so that they have a better quality of life in future. Thank you.
So, as rightly said by Dr. Durusha, today's topic, that is a very common topic. We all know that diabetes in PCOS women is a very common thing, and the glycemic profile is something which we have to keep on checking even pre-conception and even later during the pregnancy and the postpartum. So, as said, we have in the society a lot of different doctors from different fields. We have gynecologists, we have the endocrinologists, the nutritionists, the neonatologists, all who will be talking today, the experts in each field. Basically, the topic would be how does the glycemic profile get altered in the PCOS and pregnancy. So going ahead, the next slide, we have Dr. Chandrika, who will be the moderator. Dr. Chandrika Anand is the director of PCOS Center, chief consultant at Fortis Hospital, Bangalore. She's one among the top 10 gynecologists in South India, and she's been the coordinator of the endocrine committee Foxy of the South Zone, and also she's a managing committee of the PCOS, member of the PCOS Society of India. She's achieved a lot of gold medals, and a basic area of interest has been PCOS, high risk pregnancy, and research. She has been a committee member and the contributor for Foxy GCPR on PCOS 2023, and she's been awarded first prize in her research on heavy metals in PCOS at Suffolk Conference 2023. And she has been also a co-editor and authored for many articles and textbook chapters. Welcome, Dr. Chandrika, on the board. And we have the experts with us will be going ahead. The next slide, please. Yeah, we have Dr. Mandurkar, who's a consultant reproductive medicine and IVF and director of Angel IVF at Wakar, postgraduate in clinical research, medical legal systems, environmental science, and in Marathi literature, who has been as current affiliations are he's a vice president of the Justosis Indian Association, the chairman SOP and Guidelines Committee of AMOGS, member of the expert group National Policy of PPH, Government of India, and an associated editor for the Elsevier publications Obstetric and Gynecology. He's already worked as a national joint secretary in Foxy in 2014 and 15, the chairman of Medical Disorders and Pregnancy Committee, the member and the National Inspection and Monitoring Committee, PCOS, Government of India. He has actually developed many medical Android applications, HTTP Justosis Score, and has had a lot of publications to his name and has been a co-editor for many of the articles. Welcome, Dr. Gora. Moving ahead, the other expert with us will be Dr. Swati Ramtek Jadhav, who's a consultant endocrinologist and endocrine oncology, Trust 12 Hospital in Bangalore. Her core interest is in endocrine oncology, mainly the thyroid, parathyroid, pituitary, and the adrenal tumors. She has a lot of publications to her name, and she's a member of Endocrine Society of India and American Thyroid Association. Welcome, ma'am. Welcome, Dr. Swati. And the last expert will be Dr. Manisha, who's a consultant neonatologist and a pediatrician from Women and Child Specialty Hospital. She's a member of IAP and ex-NNK Executive Committee member. She's a national trainer for NRP and NSSK. She's a national assessor for NICU accreditation program. She's trained many students for the fellowship courses and a lactational consultant, and has written penned down many articles in the index journals and chapters in neonatology books. Welcome all on the board. To move ahead as a series.
So good evening, everyone. Thanks to PCOS Society of India. Thanks to Durusha ma'am for giving us a wonderful opportunity. I have personally heard Dr. Gorak sir speaking, Dr. Swati speaking, and Dr. Manisha speaking. So it is my fortune that all of you, I could get all of you together and you instantly agreed. Gorak sir will give a very practical outlook of any condition. And Swati is extremely interesting in explaining the pathophysiology part. I've heard her talk about brain and PCOS. And Manisha, I work with her and she's a wonderful neonatologist, extremely good in communication. So looking forward for a very interactive session with all of you. So giving an introduction, so all of us are aware that PCOS is a very common condition with around 10 to 12% of reproductive age group women all over the world suffering from that. And also we know that gestational diabetes also is a common condition. Around 7 to 18% of pregnancies do have maternal diabetes. So both together can make a very deadly combination, increasing the risk of further risk of adding preeclampsia, cesarean, fetal complications, malformation, and all that. And also there is a consequence for the offspring in a later life also. So this that is the reason. So we need to work on the PCOS patients being at risk for gestational diabetes and being and what else can add up. So I just want to ask Gorak sir. So like we know we have so many patients with PCOS coming to our outpatient, particularly the infertility. The fertility clinics are most of the patients have PCOS component. So when we are counseling the patients, when we are seeing the patients, what all complications of pregnancy, that is in general, a woman with PCOS becomes pregnant either on her own or with a treatment. What are complications should we doctors be ready, and also should make the patients be ready to face the pregnancy, sir?
Right. So at the outset, first of all, I thank Dr. Durusha Madam for involving in this webinar. Thank you for kind words. And I'm sorry, Dr. Chandrika Madam, that I could not answer your two calls.
No problem.
But right. So yes, when you rightly said that the PCOS and GDM both are very dangerous things, and now they are increasing like anything. And one line we all must keep in our mind that our Indian women, they are almost 11 to 12 times high risk than the Caucasian population for all these metabolic syndromes. And that's why any lady, when she comes in our OPD, let's say for fertility or infertility, or even with pregnancy and or with GDM, then we all must discuss about with her regarding all the complications, right from conception to the early miscarriages, to the recurrent miscarriages, even to the associated early anomalies. Then later on regarding the preterm delivery. Even if at all she goes in the labor, then probably the induction or the elective cesarean section, that means either or operative deliveries they may be required, or even we have to discuss with her that because your uterus is again in the pool of that hyperglycemia, so it is very high risk to undergo the postpartum hemorrhage as well.
Correct.
And these are not only the complications of mother, but regarding the baby also we have to discuss. Ki Papa, these are the complications. Like say for example, even the prematurity can be the problem, the infections can be the problem. Even immediately just after the delivery, the hypoglycemias, hypocalcemias, NICU admissions. Already we have discussed about anomalies. Then all these. So we have to discuss, though we are not frightening that lady, but we have to discuss that whenever you are a known case of PCOS or you are a GDM, then there are certain lists of complications which may occur, and that's why it is our sincere thing that you and me, we both should work honestly to keep your sugar levels always in a proper given level. So if we discuss all these things right at the beginning of the pregnancy, then probably it becomes easy. And we should not only discuss this with the lady, but her all family members. That is very important. And if we just sit together and we tell them, even you are at high risk to develop hypertension because of this your tendency. So we are not frightening you, but we are making you realize where you are and where you can be if the things go uncontrolled. So if we talk in this way, probably they will come in our line and they will give us good support and the treatment can be done very well.
Correct. Yeah, I totally agree with you, sir. So, in PCOS, all of us know that the miscarriage rates is almost up to 40%, and gestational diabetes is around 50%, and 10% risk of preeclampsia, and 10% risk of preterm labor, and 10% risk of small for gestational age. But as sir told, one woman can have multiple problems. In the sense, she can develop preeclampsia also on gestational diabetes. It's gestational diabetes and a miscarriage. So, getting pregnant with PCOS is not an easy task for both for the doctors and the family. Manisha, I just want to jump to a neonatologist. Why you don't like babies with gestational diabetes mothers? Because or in general diabetic mothers. Why you want? Why in the long term you've seen so many children from neonatology to pediatric practice? So like, do you even though however difficulties is there, you can manage, I'm sure. But then, do you want women to have normal glucose, or you are okay with high glucose because you can manage or we can manage? What are the long-term things? Why you prefer a euglycemic woman? You're muted, Manisha. You are muted. Please unmute.
Thank you, ma'am. Thank you for considering me for this discussion. This is one of the favorite topics. Though, because the infant of diabetic mothers, they look so well and well grown. People are very happy to, that the baby gundu gunda gire. This is what generally the outlook, the babies. So I have a last baby last month, I would say about 4.7 kgs. That baby looked, and parents were so happy that it looked like a 3-month-old child. But as you said, the gestational diabetes or the poor glucose tolerance, prevention is much better than having it. So why? So the question is why these babies of the GDM are at risk, ma'am. So pregnancy, as we all know, it's a diabetogenic condition, and glucose, for that matter, whether it's high or low, both are not good. And glucose is teratogenic. So what happens that during the periconceptional period, because as sir said, now the India is becoming towards the diabetic capital of the world. So there are many cases. What we used to see is infant of a diabetic mother having diabetes during pregnancy. Now we are seeing many type 2 diabetes mellitus getting pregnant. So what is happening is that during the periconceptional period, if we have the poor glucose tolerance or the maternal hyperglycemia, sugar being the teratogenic, it will have the effect on the development or the proliferation or the development of the fetal organs. So it may include the muscle cells, all the adipocytes, or it may include even the brain cortex. So everything is affected. So when we say about GDM, it is not only the periconceptional, it is during the fetal part, that is when the baby is inside the womb, the neonatal part when the baby is born, or during the time of the delivery, because the babies are large. And not only it stops at neonatal period, it is a long-term effect. So we are looking at, till the adolescent age group. So this is not something which is, having to be controlled only during the pregnancy. This one will have effect on the baby even at the long term. So we always would like to have, the mothers with the good glycemic control, because the diabetogenic condition is a suboptimal, intrauterine environment for the baby, which can have a long-term effect on the baby, and it is not good for the growth and development of the fetus. I shall come to the specific complication later, but what we have to understand is periconceptional, fetal, neonatal, and long-term. As the Barker said, it is the fetal origin of the adult diseases. It starts at this level, ma'am. So we would always want you to have, and if you give us a baby which is without the, it is without having the sugars being normal, or there is what the underlying thing, what I can say is that even if it's IDM, it's well controlled. There is a 95% chance that the child will be healthy. So having a good control is also equally important.
Correct. Rightly said. I think Gorakh sir, now that Manisha is sharing her experience that she is seeing a lot of diabetic mothers, do you think the prevalence of GDM and PCOS is increasing in India? And what are the possible factors do you see in your practice? You are so experienced. Do you see any shift in the lifestyle? What exactly could be the reason for this, sir?
Right, you are rightly said, madam. Actually, the incidence is increasing like anything. And initially, it was said in many papers that it was from 4 to 10%. But if you see the worldwide statistics, it varies from 5 to 45%. And in many areas, if we see our own Indian geographic variations, then it varies from maybe 6 to 10% from the Jammu. But if we go in Telangana, in Maharashtra, in Karnataka, there are certain places where the incidence has gone up to 18 to 20%. In my own clinical data, in my area, we have 22% of the GDM.
My goodness.
So it has gone that much. If we see carefully, probably the variations are because we are not doing we should not say, but we are not doing the screening test properly. And each and every woman is not getting screened, and that's why there are geographical variations. But otherwise, yes, India is reaching up to more than 25%. And if we see the causes, if we see the causes, yes, it is not only the altered diet, but lack of exercise. Second thing, childhood obesity. For me, what I feel is childhood obesity, and now these girls, they are becoming the mothers. So it was actually the problem was there 15 to 20 years back. And now we are getting the bad fruits out of it. That is number one. Second thing, they are marrying very late. So even the age at the marriage is also a problematic thing. Third thing, as I already said, the dietary problems. Junk food, they are eating like anything. But again, I will say here, it is not only junk food, because we have one beautiful study in our area that was mapping. That is a metabolic assessment of polycystic in India. And there we have a great population which was eating only one carbohydrate diet. And they are actually climbing the mountains, and they are taking the water and uh, chas and etc. There, that is a very simple population. But again, here I will say that population, what we found was a piece that population was with PCOS. So though they were not taking the junk food and all, but because of the PCOS, that population is at risk. And that's why. And even there are certain genetic factors. And another important thing, what we are not seeing are the epigenetic factors. Because what has happened in their mothers, we are not understanding what is happening. Here, just I would like to give one example, and then I will conclude. If you remember our grandmothers, they were healthy. But if you see their children, that means our parents, they were not healthy. So probably they were from maybe 50 to 70s. So they have that malnutrition status. We are their children. We are too much healthy. And that's why our children, they are looking healthy, as Dr. She was saying, looking healthy, but they are not healthy. It is again a very complicated epigenetic. But we have to understand this. And it is because again, I will just divert one line, that why the cesarean sections and why the hair circumference is increasing like anything. It is again connected with all these things. So we have to understand these genetic and epigenetic factors as well. So I think this all is causing a lot of hell of a problem, and we are going towards the capital of GDM and PCOS.
Exactly. I totally agree with you, sir. So as you told, epigenetics matters a lot, because we have seen a lot of obese women not having PCOS. Apparently, younger women having premature ovarian failure. So we need to stress on the environmental toxins or endocrine disruptors. That is, our everyday use of plastics and cosmetics and exposure to chemicals has become too much. On an average, I believe one woman is exposed to 127 chemicals in a day, in the form of different soaps and perfumes and powder and shampoo, conditioner, plastics, and all those things. Also, our cooking habits have changed, sir. We are using a lot of Teflon coated tawas, non-stick tawas, and then we are using a lot of this plastics and melamine. and putting the food in the freezer and then reheating in the microwave. All this, I believe, is causing a lot of problems. And even the gut microbiota also has got a role in it. And as you told, it is not only the diabetes which is increasing, PCOS also is increasing, thyroid also is increasing, and rural-urban divide also is slowly narrowing down. The prevalence of all these diseases, before it was very less in rural and it was very high in rural urban. Now it is overlapping. So, Dr. Swati, now you are a very intelligent woman in explaining the pathophysiology, I should say again. So, what exactly happens in this gestational woman, and what do you think of the common risk factors? Like, there we know all these endocrine risk factors and environmental factors. So, what exactly are already present in PCOS, which makes her more prone for gestational diabetes, and why, as gynaecs, we should be very responsible about it?
So, for understanding what exactly happens in GDM, we have to look a little into what happens in a normal pregnancy. So, normal pregnancy, when a fetus enters a maternal womb, the maternal system has to prepare to provide for that fetus, and that provision has to be a continuous basis. And glucose is the best substrate for the fetus for all organogenesis and requirement for the fetus. So the maternal metabolism prepares for this fetus. In the first trimester, the fetal demands are not so much. So the insulin sensitivity in the mother goes down. That means mothers become more insulin sensitive, so that more of the glucose can be uptake and it can be stored in adipose tissue in anticipation that in the coming second and third trimesters, when fetal growth is going to happen, then the fuel can be supplied to the fetus in second and third trimester. Accordingly, in second and third trimester, insulin resistance goes up. And the mediators for insulin resistance are placental lactogen and a host of other hormones, progesterone and all the other hormones. And the purpose of increasing this insulin resistance is so that the maternal tissues won't take up that much glucose, and the glucose, there is a gradient which is maintained from the maternal side to the fetal side for the glucose to pass very nicely to the fetus. Not only does the maternal tissue don't take up glucose, but there are gluconeogenesis increasing. More glucose is produced by maternal liver, so that even in fasting state, the supply to the fetus should remain uninterrupted. And to accompany that, in a normal mother, the insulin secretion capacity almost doubles during pregnancy. So the pancreas of mother need to have that kind of insulin reserve to support the supply of fuel to the fetus. So this is what nature has made arrangement for the fetus to come into play. But then in a patient who develops gestational diabetes, she has not developed just like that. I mean, it is a complex interplay of both the things. It is a complex interplay of not only the environmental factors that we discussed, genetics also play a very important role into that, and this affect every aspect of it. I mean, a mother who develops GDM, the insulin resistance is more than the normal people, and so the fuel delivery to the fetus is more. And more importantly, there are some placental factors which are mediate the increased insulin secretion from the mother. And a person who is GDM, because of the known risk factors that we have, family history of diabetes, overweight, obesity, pre-pregnancy, and acanthosis nigricans in the patient, already evident insulin resistance in the patient, they also have a limited insulin reserve as well. So when the insulin resistance is going to increase naturally, it becomes 1 + 1 = 11. As well as the insulin secretion lags behind, it is not capable of meeting up to that demand, and then the sugars go up. So that is how the GDM happens.
So yeah, very beautifully explained. I think Gorakh sir, you wanted to make a point.
Yeah, actually, she very well explained. In addition to that, I would like to add one line that I don't remember where I have read, but in a beautiful article, it was written that pregnancy is a state of accelerated starvation.
Exactly.
Where what happens, there are states where the patient in the morning, she will go in the states of hypoglycemia, while postprandially, she will be in a very much hyperglycemia. Suddenly, overnight, she becomes hypoglycemic early in the morning. And that's why the nature makes like that, the fat will be taken up. And that will be used as a fuel in spite of the glucose, as what madam has said nicely. And that's why there is a mild insulin resistance which has been created by the body. So it is a state of accelerated starvation. And that's why if anything goes wrong, it deviates and gets in GDM.
Yeah, true. I totally agree, sir. So, like, apart from the insulin resistance, so like these women with PCOS, they start pregnancy with insulin resistance. Whereas women without PCOS, their insulin is normal. Their insulin resistance or sensitivity is normal. So that is why, as Dr. Swati explained beautifully, so even in the first trimester also, the resistance is high. Second and third trimester, it becomes double or more than that. It becomes exponential. So because of that, once the pancreas is exhausted with its insulin levels, so I think the hyperglycemia occurs. And also one more pathophysiological component which is common in both diabetes and in PCOS is inflammation and oxidative stress. So even inflammation happening in PCOS at the microvascular levels, that also can contribute and also it can add up to the complications of diabetes. Inflammation and oxidative stress is present both in PCO and diabetes. So now I'm sure, Swati, you must be seeing a lot of PCOS patients in your clinic who would come for maybe to you for obesity or for, insulin resistance. So when they want to conceive, what is your advice? Like, would you start a metformin? Would you start a lifestyle? Because see, when they come to us, they're already in the mode for pregnancy counseling. So we tell them things. What exactly you tell in your clinic?
So, Dr. Chandrika, mine is a very, compartmentalized approach when patient comes and utters the word fertility, that I want to become pregnant. My first thing is that regarding fertility, everything you should discuss with your fertility expert. But my job is to make the things very conducive. Your body should be conducive for the fetal to come in. So starting metformin, the intentions of starting metformin for an endocrinologist may be slightly different from the intentions with which a fertility expert might start metformin. So when we start metformin, it is for the metabolic health. It is for the reducing the insulin resistance. It is for helping them lose their weight, because metformin has one of the very good effect of reducing some appetite. Satiety effect is mild, but it is definitely there. So when a patient comes with PCOS, and suppose there are compelling factors like she is obese, she has obvious acanthosis nigricans, she has strong family history of diabetes, and in such individual I'll start metformin for metabolic benefits, and I will start it. And then regarding whether that metformin will help in ovulation or not, that I entirely leave. That is, I don't discuss that only. So that I leave with the fertility expert, and they take up from there. That whether metformin will help in that. So I don't, I won't not start metformin because she will conceive and then what, and all the controversy regarding metformin in pregnancy. I will start it if metabolically she is deserving.
Absolutely. So insulin resistance is found in almost 80 to 90% of, according to the latest international guidelines of PCOS 2023. Insulin resistance is found in more than 90% of obese PCOS and almost up to 60-70% even in lean PCOS. So like, woman who is, as you told, metabolically, she's obese and she's overweight and she's got dyslipidemia, along with when the lifestyle changes when the lifestyle intervention does not cause so much of a weight loss. See, we are aiming at a 5% weight loss to any PCOS patient, either lean or obese. And then we are, that is when the lifestyle modifications, they are not effective. Even we do start metformin. And as you told, even for the metabolic, to reverse the metabolic derangement, you start metformin. So Gorak sir, when the patient, you have already started with metformin, or the patient comes to you seeking fertility, there is a obese or a lean PCOS. Now we know insulin resistance is there even in lean PCOS. Now, are you testing for insulin routinely? And then if so, like to whom are you starting metformin so that, it affects apart from the PCOS, it will improve the fertility? What is your take on that, sir?
Very interesting question. I was waiting for it actually. We have started a very good study, that is assessment of insulin resistance in polycystic ovary patients by different methods. And there we have started comparing, the pilot data has come. We are comparing it with the fasting HOMA index. We are calculating the HOMA index by taking the ratio of fasting insulin and fasting glucose into constant. Second, we are doing in the same patient, we are using 75 gram glucose tolerance test, 2 hour, only I am using deep sea criteria. And in some patients, even we are doing HbA1c also, in the same patient. And the very classic findings are there. Mane, the clinically patient is showing that she has acanthosis nigricans. So if we suppose that it is it has the sensitivity of 90 to 100%. The presence of acanthosis nigricans, that means there is the insulin resistance. So it has a very great sensitivity. But if we find, then in almost 40 to 50% patients, HOMA index will be altered. Not in all patients. But if we see the GCT, that is glucose challenge test, then yes, in maximum number of the patients with acanthosis nigricans, the GCT is altered. So probably here we have to clear here, all of us, that when we are uttering the word insulin resistance, it is not always hyperinsulinemia. Because in many of our patients, especially the Indian population, there will be insulin resistance, but there may not be hyperinsulinemia. And that's why Dr. Swati will, and you will also agree, that all we are saying through the guidelines, that only for experimental purpose we are advocating the assessment of insulin. Otherwise, we all have come to the conclusion that 75 GCT and the presence of acanthosis nigricans, we all should take it as the test of insulin resistance, and whenever there it is, we have to start the metformin. And as Dr. Swati has rightly said, though I am a fertility consultant, I also must look towards that patient that, oh, she is in the pool of hyperglycemia and I have to save her. And that's why I have to start the metformin. So to reduce the insulin resistance, to reduce the obesity, and at the same time, if I get a benefit of ovulation, along with my ovulation induction drugs, then it is beneficial. So I think we have to have all this approach, and then probably we may give good results. Over to you.
Yeah. So like metformin obviously looks like the drug of choice for PCOS when the combined oral contraceptives are not working in cycle control. But when it comes to metabolic issues, obviously metformin is a drug of choice. And then when it comes to women who are trying for fertility, adding metformin along with the clomiphene citrate, there are a lot of studies that it improves the ovulation. May not improve the live birth rates, but then at least it definitely improves the ovulation. So we start metformin for various different reasons, either to improve the metabolism or to help in fertility, or if she already has a acanthosis. So with metformin, definitely the urine pregnancy test is positive. In a normal guy, so what is the next thing you do, sir? In the sense, now there is a PCOS woman who was trying for pregnancy. She has lost weight and you have given metformin. Now the pregnancy is positive. Now there pops up a controversy. So should we continue metformin even though if her sugar is normal or only if the sugar is high?
Right. Ideally, here again, that is a very interesting question because lots of controversies are going on. And if we see the data, then 50% data says, no, we should not. 50% data says we should discontinue. But if we see our patients, then yes, ideally we should continue, because again, it is not once she has become pregnant, that means all her risks has gone. Right. See, whatever we have started the metformin, it is to control the risks. Correct. It is to prevent the complications of the insulin resistance. Correct. So ideally, we should continue. Yes. Number two, again, you, I think, asked which. So because, see, there was a beautiful study and there they compared the routine metformin with extended release and with sustained release again. Correct. But they never got good results with the sustained or the extended release metformin, but they got good results with the routine metformin preparation. Okay. And again, it is the category B drug. So definitely we can continue. And now literature is showing that there is no teratogenicity. So because of the metformin, so definitely we can continue. And if she is GDM or something, then we have to have in the proper dosages with the proper blood glucose monitoring.
Yes, I totally
One
agree.
line, madam, I will. Yes, you said regarding the OC pills. Ideally, now, whenever any PCOS patient comes in front of us and if she wants to become pregnant, along with all these things, we have to see her androgen levels. And if she has hyperandrogenism, ideally, I will request and recommend that for 2 months at least, she should be on a very good combination of either drospirenone or cyproterone plus metformin plus vitamin D3 plus folic acid plus exercise plus diet, and I think we can reduce all the complications during the pregnancy. I think that is the best combination we have to have in our mind.
Absolutely perfect, because as sir told, hyperandrogenemia, either clinical or biochemical hyperandrogenemia, is evident in more than 70 to 80% of women with PCOS. Only around 10-20% of PCOS women do not have hyperandrogenemia. They go to the group phenotype D. They have the least complications. So hyperandrogenemia is a very strong predictor of complications in PCOS. And if it is either evident clinically or biochemically in the pre-pregnancy state, that is when the patient is still seeing the endocrine, or when she is still planning for pregnancy, I think giving 2 cycles of androgen suppression helps a lot in preventing the complications, particularly the preeclampsia and the small for gestational age, which because it is known that the androgen interferes with the uteroplacental circulation and that cytotrophoblast and syncytial trophoblast invasion in the 12 and 24 weeks. So that is why the androgens being normal is very, very important. Thank you so much, sir, for making that statement. And coming back to metformin, suppose that we have given metformin to a patient with PCOS with normal blood glucose levels. She has insulin resistance, so we have given, and the pregnancy becomes positive. And now there are 2 schools of thought, as sir told, that it is good to continue in the Indian women because they are actually more prone for metabolic complications and they have diabetes. But then the Lancet says that in the first 3 months you stop metformin, because it is studied that it is a retrospective study in the childhood obesity is more common in women for whom metformin was given in the first 3 months. Even though we are yet to accept that and yet to reduce that, we need more Indian data, I feel. So at this context, I want to ask Manisha, have you seen these babies? You have been following up babies from almost 15-20 years. Have you seen the babies born to GDM mothers as they grow up? Do you think there is any unique issue like, obesity, weight gain, and eating disorders? Do you see anything in your clinical practice that, women born to diabetes, there are babies born to diabetes, when they grow up in childhood, do you have any comments on them?
Yes, ma'am. So basically, when we talk about the GTM, as I told you, from the periconceptional to the fetal to the neonatal to the long-term effects. So their long-term effects is something, people are not aware about or not want to accept the fact, In the OPD, it is not easy for us to tell. If I tell a child is obese, people don't accept it and do not like it the way we say it, if the child is above the line. So now we have put up those growth charts and we tell them that, the child is over and above these lines. So cut down, and with lot of junks available now, it is very difficult for us to tell. So the acceptance and the awareness is more important from the parent side. Now you start with from the fetal side, madam, as we know that the first trimester, second and third trimester, in the first trimester, the child can have congenital malformation, fetal wastage. In the second trimester, it can have preeclampsia, polyhydramnios, IUGR babies, and the third trimester about the neonatal morbidities like respiratory distress syndrome or macrosomia or congenital malformations or any metabolic syndromes like polycythemia, hyperbilirubinemia. Now, when we consider about the long-term complications in the childhood, there is a lot of data which they have no linear relationships they have seen in children who have been growth on the growth chart. They have plotted up to 8 years and till the adolescent age group. So we do not have till the adults, but till the adolescent age groups, and there is something as we call as metabolic syndrome. So we are seeing this in childhood obesity. So it's an independent risk factor for children who are born through the mothers of the diabetes. So that is childhood obesity, and it's associated with metabolic syndrome, like they are more prone for the type 2 diabetes mellitus. It's an independent risk factors irrespective of genetics. So one is childhood obesity. There is a eating habits which are being, they are more, tend to eat more and tend to have on a higher side of more than 95th percentile on the childhood obesity. At the same time, when I say that metabolic syndrome, which connects the obesity, cardiovascular disease, and the type 2 diabetes mellitus at the later stage. The something which people are not yet about is a very, very independent risk factor for the children who are born to. So there is no gross neurological abnormalities, but there is something called as minimal brain dysfunction. So which they will know only at the age of, the child starts going to school. So it is basically on the psychomotor. We call it as neuropsychological deficits, So mainly on the intellect, mainly on the memory. That is because the poor glucose tolerance during the periconception area affects the hippocampus. So that is the main area which affected, and that's why their memory is affected, their intellect is affected. So they, on a plot, they score a little lesser on that. And also in important, we have seen these children more hyperactive. Tend to see these children more inattentive. The concentration part is very, very less in them. Other thing what we have seen, the language and the speech, that is also because these are all finer areas in the brain which are affected during the poor glucose tolerance. So those things you cannot see. As a child, you will see perfectly healthy child, but they come back saying that in the school going children that all these are neuropsychological problems in the child are seen. Poor academic performance because of the low intellect. Neuropsychological defects mainly in 4 domains. One is intelligence. Second is sensory in terms of language and speech, attention and hyperactivity, and psychomotor. So all these minimal brain dysfunctions are seen in this baby. So it is not only because of maternal hyperglycemia, it is also because possibility of neonatal hypoglycemia, presence of some amount of fetal hypoxia during the intrauterine environment, polycythemia, or because the baby was macrosomic, there was a birth injury. So all these, when we connect the dots, the child will have the towards till about 8 to adolescent age, we have seen these minimal brain dysfunctions. So which, when we ask back whether the mother has a diabetes, we get to know that this has an origin from the periconceptual age group.
Correct, yeah. So it is very terrifying to know all these details. I was not particularly aware about these finer details, and it is actually very terrifying to know, Manisha. So, sir, this patient who was trying for a pregnancy, women with PCOS, and then finally we put on either metformin or with only lifestyle and ovulation induction, with or without, they become pregnant and then they come to us to the clinic. So when do you start screening for gestational diabetes? Because we know they are more prone for miscarriage and gestational diabetes.
Yeah.
So when do you start? Is it only for PCOS women you start immediately, or is it universal screening? And what is your preferred method for screening for gestational diabetes?
Right. So that is very important question, and I think by the answer we all want to give a very clear statement that universal screening for the gestational diabetes is indicated, is recommended, it is needed. So that's why each and every pregnant woman must be screened for GDM. Not only in any single trimester, but in each trimester ideally. Because the glycemic dynamics is very different. Maybe a woman which was normoglycemic can become GDM in second or third trimester later on as well. So to avoid the complications, ideally, in all trimesters, she should be screened. If we see at what visit, so I will say at first visit, fine. But at least at 6 to 8 weeks, initially, she should be screened. And later on, we can say, yes, whenever we are doing the routine antenatal profile, or again, then there were so many confusions. If we see the initial DIPSI, they said 6 to 8 weeks, then at 12 weeks, then at 20 weeks, and then at 28 weeks. Then it came at 32 weeks. Then it was said ki even postpartum as well, 6 weeks postpartum as well. Simply, we can understand in each trimester she should be screened, and the preferable method will be only glucose challenge test. That means 75 gram OGTT, but again 2 hours, because we have to understand this test, it has passed through all the hurdles. It has been compared with all the data, all the tests, and now we have come to the conclusion. Again, there is a terrifying thing that initially we were been talking that the 2 hour glucose 140 milligram, if it is more than that, we were labeling the women as GDM.
Correct.
And if it was more than 200, we were labeling those women as over diabetic. But now if we see the, I will say, garam July guidelines, then they have taken that 140 to almost 126. And that is a very dangerous thing, and that's why we all have to be very serious. And I thank again Durusha ma'am, all team, Chandrika ma'am, that yes, this was a needed discussion. Because otherwise, so many things we discuss, so many things we discuss about IVF, so many things we discuss about laparoscopy and all. But this discussion was very important. So, one line message: GDM to be screened universally by GCT to our DIPSI criteria and in each trimester. Over to you.
Perfect. Sir, this DIPSI criteria says even in the non-fasting state, you can do oral glucose challenge test. But what I have felt is that some patients would have had a breakfast just half an hour back or 1 hour back. And then you give a 75 gram, I have seen that they have been high. And then you repeat the OGCT in a fasting state, maybe after a week or so, then it would be more ideal. So preferably, I think we should, as gynecologists, I think we should prefer for a fasting state. If that is not possible, I think maybe, what do you say, sir?
Here I would like to give the different opinion. What you have find is absolutely right. But again, that was the main thing to check. When we are giving the challenge with that 75 gram glucose, how the body reacts. And yes, and that's why that is the crux. Because we are not worried here ki baba, what is our fasting blood glucose level and etc. But giving the challenge, I think that is the crux. And so even in my patients, we have also studied in 50% patients we have done in the fasting status, and in 50% patients we tell them you have a good breakfast, come after 1 hour, and then ingest the 75 gram anhydrous glucose, and then do the GCT. But we have not found too much difference. Though maybe in 5 to 10% patients, yes, with postprandial, it was more little high than the fasting, but there was no much difference. Swati madam, can you throw a light on this?
Yes, sir. So, Chandrika madam, either ways is possible. I mean, to our surprise, some people on fasting, when they have tested positive, after breakfast, when we give glucose challenge, their glucose are within normal range. And we were intrigued, why, how could that happen? Because the glucose load challenge is increasing. Yes. So the physiological explanation for that was they had breakfast and they already have first phase insulin release. Already the insulin is there in the system. On that, a top of extra glucose will further increase the insulin. I mean, and that is a observation which is even published, that DIPSI, when we do in non-fasting state, it may be ultra less sensitive also, is what has been published. So
what do you recommend? Do you think it's fasting is better, one-shot fasting, or?
So my personal thing is that DIPSI is a very responsible, policy. It's a policy making thing. So all the experts come together and they don't have to think about what they will do in their clinic. If I am sitting in a tertiary care center now in Bangalore and previously at KEM Mumbai, so we are not, we don't think like a policy maker. Policy maker has to think what will happen in a PHC. When a patient, a pregnant patient is just for coming to the clinic, she has to let go of her daily wages. Just coming is one disadvantage for her, because she is losing her daily wage job that day, and then calling her again, now you come another day. So for a policy maker, it's important to see what is the best trade-off between the sensitivity and the specificity, so that you don't risk high risk patients, you don't miss, and you don't unnecessarily burden the patients who are low risk. But I am sitting at a tertiary care center. I don't have that kind of responsibility on my shoulders. So I will, I honestly speaking, I do IID PSG. And for a person who is coming to a tertiary care center, we compare DIPSI against this IID PSG as a gold standard. So why not to do that when I don't have that shoulder responsibility to shoulder with? Why shouldn't I do the gold standard against which it is compared? And this 140 in DIPSI has first been taken from 1999 WHO guidelines. That was the reference. That was pre-HAPO period. So once HAPO has happened, and based on those deliberations, IDPSG has come up with the cutoffs. It is little cumbersome, I agree, and I fully support DIPSI in that regards, that it's a great national responsibility that they had taken up. But my personal small opinion, what I follow in my clinic is 3 hours IDPSG.
Okay. What an eye-opening conversation this was, sir. We are sitting here talking about whether to do fasting or non-fasting and false positive, false negative. Then Swati hits the sixer, telling that, it is not only my and your patient sitting in tertiary clinic. We are talking about rural people. As you told, coming to our ANC itself is such a big task, and for them, DIPSI and the national and the government telling that, okay, now you drink the glucose, at least we will know whether you are having diabetes or not. It's a wonderful insight you have given, Swati. Thank you so much. Thank you, sir. I think, sir, now also I need to ask you a question. So there is a PCOS, and then you have done the obesity. Do you do the HbA1c in the first trimester? And what is the importance of this HbA1c in the first trimester?
Right. To be frank, in non-PCO, non-obese, I do not do HbA1c. Very frank and clear opinion. But yes, once we know yes, he was a known case of insulin resistance or PCO patient, then yes, we do. Because again, many a times, as Madam was saying, GCT may not give the idea, but HbA1c definitely gives the idea regarding the, as I always say, the glycemic pool, about the glycemic pool. And that's why HbA1c, yes, but routine recommendation is again not done, as Madam has rightly said. As a national policy, when we see it is not possible, but yes, in our OPD, if we have the obese patient, if we have the PCO patients, one must do. So we will come to know that though her GCT is normal, but because her HbA1c is on higher side, she is at very high risk to develop the GDM in second and third trimester.
Correct.
Again, that was a very much important thing. So we have to have. So like, I always say in the lectures of hypothyroidism, there are the patients who are sitting on the edge of the table, and once they become pregnant, suddenly they become hypothyroid. And then we miss them because we have done the TSH on the first day or on the first day of the ANC, and then we forget it. But these are the patients who are at very high risk to develop the hypothyroidism once the pregnancy advances. So likewise, even these are the patients whose GCT may come normal, but they are at very high risk to develop the GDM in the second and third trimester. So we have to have the knowledge of the HbA1c in such patients.
Perfect. Also, apart from the glycemic pool or the risk of developing gestational diabetes later in the second trimester, incidentally, suppose there is an unbooked PCOS and she just says she is pregnant, and now she had a history of PCOS. Maybe we will presume that she didn't come to any gynec and got a pre-pregnancy counseling properly. For her, apart from the glycemic profile, very high HbA1c also can, in the first trimester, can increase the risk of fetal anomalies. A HbA1c more than 9% in the first trimester almost equal the risk of developing a fetal anomaly, major anomaly, is around 25%. Do you agree, sir?
I agree absolutely, madam. Yeah, absolutely.
Yeah. So I think in the woman with PCOS who has not really made sure that her glycemic level is normal, or a obese woman, as sir told, if the sugar is high, automatically please do a HbA1c. Or also there are some women who do not tolerate the glucose challenge. They may vomit, they could be having hyperemesis. That is when fasting sugar or a HbA1c can also help in diagnosing the gestational diabetes. So Swati, like now I just want to ask you, in your practice, at what stage do these doctors, that is gynecologists, refer the patients or at what stage the patients come to you with diabetes? How do you counsel them? Suppose I have a patient and she has developed gestational diabetes and her sugars are high. So how do you take them on?
So I would say that it has changed. I mean, when I used to work at a KM hospital, all across the spectrum, the patients used to get referred. maybe as a department policy in obstetric and gynecology department, right from just one level, fasting 95 and rest all normal also used to get referred, to the frank diabetic in first trimester also used to get referred. But nowadays what I had experienced was the proper GDM. I mean, only onset in second trimester, third trimester, mildly high sugars, they are actually not getting referred. Probably they are, because as we understand, 80% of them will get managed on diet only. So I'm seeing those patients a little less. What I'm seeing more is a little difficult to manage diabetic patients in pregnancy, obese patients, and even in first trimester, who are having positive screen to the extent of diabetic levels. I mean, non-pregnant diabetic levels. Those are the patients who are generally nowadays referred to me. And when they come to us, obviously, as sir had beautifully described, that we have to counsel them regarding all the complications which are described, but in a non-threatening way. Because as a fact, as a published fact, the outcomes of well-managed GDM are approaching to normal pregnancy levels, because we nowadays we manage them very well, and they get managed very well. So those kinds of I mean, GDM literature started with description of perinatal mortality. Those were the days when it started. So those are no longer the days now. So that should reflect in our conversation with the patient, as sir rightly said. And the thing would be just to give them an informed decision and take their cooperation in managing the diabetes throughout pregnancy.
So as you told, most of the people do very well with diet. So what kind of diet broadly do you give to these patients?
So when I read the literature, again, there are numbers. 180 grams of carbohydrate should be there. 60 to 70% is too much. 50 to 60% carbohydrate is better. Other studies will say, no, 35 to 40% carbohydrate will be. But actually speaking, how can there be one prescription for patients? All the patients, somebody is 80 kg, somebody is 60 kg, somebody is 40 kg, somebody is 60 kg, but normally she eats only 2 idlis. Somebody is 40 kg, normally she eats 6 idlis. So how can we generalize a diet pattern like that? So for this sake of this discussion, actually I went and read the numbers. Otherwise, I don't read the numbers. I manage the patient first by taking their dietary history. What are they taking? What were they taking pre-pregnancy? And what has happened after pregnancy was diagnosed, because there are mother-in-laws and mothers who would say you have to eat for 2% now. So what change has happened? And I try to just cut down the carbohydrate content from existing diet. If there are 4 idlis, 2 idlis, increase sambar. So what I try to do is cut down on carb. I honestly don't know how much percentage of that is contributing to their total energy intake. Although as an endocrinologist, I should know. And so I read it, but then I don't follow that. What I follow is what the patient is taking exactly, the entire dietary history, and what to cut down and what to increase out of which. And then in follow-up, then she feels hungry at that time. So what to supplement it,
Yes,
like with fruits or with
yes.
buttermilk. I mean, to go on like that, to starting point is not what is written in the guidelines, but starting point is where she has started, and how do we modify it along the way.
Fantastic. Yeah, fantastic. Sir, do you want to add on anything, sir?
Yes, yes, I want to add on it, madam. And that's why even I do the practice in the same way. And so I have written as a designation as a diet designer and not as a dietitian. So what we do is, and that's why I always advocate that we should write that diet designer. Once you write that, na, the people are also happy. So we tell them कि आप जो खाते हो, please give us. Last 5 दिन में आपने क्या क्या खाया, please give us. So that we will design it. We will cut this, we will add this. We will cut this, we will add this. So absolutely correct methodology, madam. Great, thank you.
Fantastic. Yeah. So because it's so theoretical that we can't measure the grams of COH, CHO, and then they become very depressed actually. The food craving will start, and everyone they're forcing so much food, and then we tell them don't eat these things. It can be very hard on them. So like at what point, Swati, you have already advised diet, and then you've given a diet design as sir told. And then at what point do you think we should start medications for diabetes in pregnancy? And how do you decide personally? day. That is whether it is insulin. See, all of us know theoretically insulin is the best treatment, but then most of us now are switching on to metformin. That apart, what exactly, how do you decide? How do you decide which is when do you start the medication and which medication do you start?
So that major part of is decided by the degree of dysglycemia that they had presented with. Somebody who has presented with more than 200 of sugars, then obviously I won't play around more time with giving to diet alone. Although I understand that diet has the potential to reduce even that, but I won't go with that. More than 200 sugars, I would start on insulin directly. But somebody who is having just a minimal 180s, 160s, 170s of postprandial hyperglycemias, there I would go along with diet, mainly with diet. Regarding insulin, before adding insulin, my personal predisposition towards insulin is looking the overall picture, not just the sugar levels. I mean, as I said, very overweight, very acanthotic patient, and already gestational weight gain has happened before she came to me. Already she has crossed the limits of weight gain. I would prefer insulin because insulin is shown to reduce the gestational weight gain. So in those situations, I will use metformin, but the degree of dysglycemia would decide on the insulin versus this thing. And one thing which I stress on right from day one is SMBGs. I ask them that they should purchase a glucometer and they should start monitoring whether it is diet, whether it is metformin, whether it is insulin. I tell them that that is the only thing which will empower me to decide what to do next when you come for the next visit. And we don't have time here to waste upon. So they should start monitoring it. And more than 200, I start insulin straight away. Less than 200, I start with diet, and plus minus metformin, I decide based on a case-to-case basis. And based on the further SMBGs, then I decide whether which insulin to add and how to adjust it further.
Perfect. Sir, do you want to add anything, sir, or change anything?
Absolutely, I absolutely agree. Because even whenever I work with a physician, my senior physician, Dr. Gosavi, so we are following the same. Okay, whenever it goes beyond 200, then yes. And again, we also insist on the monitoring. Even we have given them the chotas notebooks.
Correct.
You please write that and you send us. And depending upon that, we decide which insulin and in what dose. So that is a absolutely right thing.
Perfect. I think as Swati told, giving them a diet design and asking them to write down what they eat, and also insisting on a self-home monitoring of the blood glucose levels, and they have to write down in a book. Otherwise they'll carry 100 sheets, and we don't have the patience, and we can't compare at a glance. So I think giving them a book along with their diet and their diet diary, and then I think maybe after 7-8 months we need to start recording the daily fetal movement count also, as a part of our antepartum surveillance, which I'll come to that later. So Swati, how often do you ask them to monitor? Daily, weekly, 15 days once, monthly once?
So initial period is the period of titration. I want to know what her requirement as such is. So initially I ask them to monitor minimum 4 sugars, fasting and postprandial, all the 3 meals, or maximum 6 sugars for initial 1 to 2 weeks at least. That will, that will make them get used to sugar monitoring, and I will get an idea what is her this thing. And 2 weeks is the period when I go on titration, titrating a lot. And once that is achieved, I'm talking about some person who have started insulin upfront, more than 200 sugars. So I go a little more aggressive in monitoring sugars and titrating the insulin doses. Some person whom I am trying just a dietary thing, only diet management, there I can reduce the frequency of testing to 2 sugars to 1 sugar every day. Alternately different sugars, but at least 1 to 2 sugars a day. But any whichever way, initial 1 to 2 weeks, I am very more insistent on monitoring more frequently. After 1 to 2 weeks, she also understands her pattern. I also understand the pattern of the patient, and then it can be reduced to alternate day testing also.
Okay. And also can you give me a one-line comment on continuous glucose monitoring system?
CGMS is a boon. It's a boon. I mean, it's a very good modality. There are a lot of data which is coming up to say that it is accurate. You can believe those readings. Personal experiences, it is accurate in mid ranges. But when it comes to low ranges, like when CGM is showing 50 of sugar, In non-diabetic also, in non-diabetic, we are not much bothered. If the patient is asymptomatic, we understand that is the tendency nighttime. Even normal people, if you do CGMS, the readings can go up to 50s, what is shown. So in pregnancy, we don't want hypoglycemias. We don't want fetal to face that. So in those situations where CGM is showing low sugar, we ask them to counter check with the glucometer reading to say how much it is, and we take that seriously. We do the reduction in insulin levels based on those low values as well. Otherwise, CGM is a boon. I mean, if the patient can afford, it should be done.
Absolutely. I totally agree with you, sir. Coming back to the antepartum management, in the sense that we have diagnosed, we have sent the patient to Swati and she started diet and insulin or metformin. Now, what extra care are we taking? Because we know the fetal anomalies are increased in gestational diabetes. So can you say a word or two about the anomalies and how do we screen for
Right.
them during
Yes.
GDM, sir?
The very important thing, even though very well managed case, then yes, the chances of anomalies are very little, even in a very well managed case. But still, whenever we know my patient is PCO or GDM or over DM, it is our duty to give the extra care. Because again, all the central anomalies are more common. And as that question was asked again, the sacral agenesis, that is a very commonest anomaly that is being said, in especially the GDM, or even we describe the patient that all the central anomalies are common, and that's why we are going to do your anomaly scan. And again, here I will request all my obstetricians colleagues that please do not do the anomaly scan on your own unless until you are very well trained and certified, because again there is a court order, because I'm here again to discuss that as well, because it has a medical legal implication as well. So from the safety of the baby, from the safety of a mother, from the safety of your practice, and from safety of yourself, I will request here the level 3 scan, and that is from a radiologist. Later on, yes, as we have done the early scans, anomaly scan has to be done, even the fetal echocardiography, because that is very important. Again, we know that the incidence of cardiac anomalies is more common. So we have to be here choosy. See, again, as Madam was saying, because I am in that side also, worked in that side also of making the national policies and all, we always say here, we are not saying fetal echo for all, but at least the fetal echo in these patients, that is must be carried out. And nowadays, even all the government college facility, they have the facilities. And yes, we have to discuss with the patient, even if she is not affording, this is important because later on this may trouble you. So fetal echo. Lastly, as you are asking the whole antepartum, yes, the Doppler studies, they are there. They are very important because again, she is very high risk to develop the metabolic syndrome. Not only that, the preeclampsia, even see, though here IUGR is not common, and IUGR will be very dangerous if it's associated with GDM, because that will show that the whole system is collapsed. But here, Doppler studies are very important because we have to do the careful monitoring. When to deliver her, whether the parameters are going haywire, we have to induce her in time, we have to deliver in time. So to take those decisions, I think yes, the Doppler studies, they are very important, and all other antenatal surveillance wherever required. It may be, I will say, 1.5 to 2 times more the normal case. That we have to keep in mind. We cannot say like that, there the way we are doing monthly, here we should do 15 daily and etc. We cannot, we have to individualize the need. We have to see the patient, and depending upon that, but definitely more vigilance to such patients. Over to you.
Perfect. Because sir very, very rightly told that now that she's got gestational diabetes, we are focusing only on the diabetes and forgetting that, this obese woman at an advanced stage or elderly woman with a PCOS is also prone for preeclampsia. So we need to make sure that, we are doing the uterine artery Doppler at 12 weeks, 24 weeks, whether to start aspirin as an add-on to all these issues, and also monitor the PP very regularly. So all these things, these points we need to check. And also, like as sir told, sacral agenesis or the caudal regression syndrome is most commonly found in gestational in diabetics. But then cardiac anomalies the highest anomaly or the most common anomaly is a transposition of the great vessels, apart from the tetralogy of Fallot. But very uniquely, this caudal regression syndrome is found in diabetes.
And even in I'm sorry to interrupt, but even in our Justosi score, we have taken GDM as a very high risk criteria. So whenever any gravida, when she becomes GDM, then she is at risk to develop the preeclampsia, and she should be started 75 milligram of the aspirin at the bedtime, along with 1 gram of the calcium, as soon as we detect the GDM. So that is what we recommend through the Justosi score. So even we do not wait for the doctor studies at 13 or 20 weeks.
Yeah, absolutely.
So that is now a recommendation given by the Foxy ICOG and Justosis as well.
Yes. Nagaditya and Aditya, now I have to ask you one question. Should we finish at 7:30 or should I hurry through or can we extend?
Ma'am, we can extend. Akshita?
But I think I have to go at 7:30. Because I'm going to play a drama. So right here, from here, I'm going on
so
the stage.
interesting, sir. Like, I'm myself, I'm learning so much from all of you.
But it is
Anyways,
really fantastic.
we'll try to run through this anyway. Thank you so much.
One thing I just wanted to add, when sir said the echo thing, so structural anomaly wise, yes, transposition of great vessels is the commonest one, but what we see is the hypertrophied septal hypertrophy. That's the commonest echocardiological finding what we see. So why I said this, when sir said medico-legal, when we tell them it's a problem which we'll see after the baby is born and when the circuit is started. See, inside the womb it is not. So these are outflow tract obstruction because of the septal hypertrophy. And this we will know only after the baby is born. So the commonest question asked to us is why it was not detected during the scan. Why they didn't do the fetal echo. So that is what. So we have to tell. We generally tell them that this is a structural. It is not a structural problem. It's a functional problem which we will get to know once the baby is born and the baby's heart starts functioning. So the commonest echocardiographic finding what we see is the septal hypertrophy. Just to add on that.
Yes, absolutely. So learning so many new things in this discussion. Thanks, Manisha, for that input. Sir, shall we quickly run through the when to induce for this woman and then what are the intrapartum complications of a gestational diabetes patient?
Okay, right. Actually, we should not hurry, number one. That is very important thing, because if we do hurry, then it will cause a problem. Just keeping in a mind that she is my diabetic patient and then I have to induce her very early. It is not like that. Proper maturity should be seen, number one. Second thing, as soon as till as mother is fine, till maternal surveillance is fantastic, then the baby findings are normal. Yes, full term we can take to, and then we can induce. Because no guideline says, because it is not a case of a preeclampsia. We are talking about a plain case of diabetes now. But usually these cases, they come with other complications. And that's why when she is associated with preeclampsia and all, so again the maternal risks will go high. So one cannot individually give the statement that at this stage or at these weeks, she should be induced. But depending upon the maternal and fetal surveillance test, we have to take the decision. Number two, if a time comes, we have to induce her very early, then we should see that there is sufficient maturity of the fetal lungs. And that's why whenever a question is asked, your patient is diabetic or she's GDM, are you going to give her again steroids? The answer is yes. Because though she is diabetic, I will do the proper monitoring of the sugar. I may increase 1 or 2 units of the insulin. But if needed, I will give the steroid in a proper dose with supervision. Because again, for me, the outcome of the pregnancy, that is the fetal lung maturity, is very important.
Absolutely. Totally.
Coming to the complications, yes. Again, sudden uncaused neonatal deaths, fetal deaths, intrauterine fetal deaths, they are very common, and that's why we are very much worried. And that's why in many cases we do the hurry. But I think we should do, as madam you were saying, that whenever we are giving them the book, then and if they are maintaining their sugar levels properly, because after the COVID era, they are looking their pulse oximeter, they are doing their blood pressure monitors at their home. So now they are doing very well monitoring. monitoring. So if everything is fine, one should not worry. But we must tell them if you find a single complication that you are not getting any movement, etc., immediately you should come to the clinic. And if you are at remote place, we tell them you should come at least whenever you complete the 37 weeks to the nearest relative near to the hospital, because you are a classic case and we must give some attention. Another complication, usually we all know that these GDM or DM patients, they go in
bigger babies.
yeah,
Macrosomia, shoulder dystocia.
the macrosomia. I'm sorry, macrosomia. So one must be careful that, oh, if I am doing the vaginal delivery, then one must keep in mind that shoulder dystocia is very common. And at least if you are delivering a patient, then we must understand okay, I have the recent sonography report where at least this is the baby weight, or clinically I am finding that this baby is too big. I am finding that probably the pelvis is not that, I'm not satisfied, but still the delivery is happening. Then I will request here that if you have experience, fantastic. If you do not have, please give call to the senior obstetrician nearby you that please come here and attend the delivery, because probably if the baby goes in the shoulder dystocia, then one must know what is Mac Roberts, what is corkscrew. One must not know the Zavanili and all. That is, forget about it. These are the bookish maneuvers. But at least the hyperflexion of the thighs, then giving the good suprapubic pressure in with the proper contraction, then doing the proper corkscrew. So all these maneuvers one must mug up. See, whenever I always say, I'm in that process of making the checklist. When you know na ki my patient is of GDM, then before delivering, at least when I time, I should open this and I should see what is Mac Roberts, what is Crook, and etc. We should give 2 minutes, and then there will not be a problem. And at the same time, last complication, and then I will conclude, is her sugar levels, because here again we forget. Now she is delivering, that means we are coming out of the diabetes. No, it is again a problem, because when patient is on insulin, one must inform the physician that my patient is going to deliver tomorrow, or I am going to induce, or she is undergoing cesarean section, and please give me, Baba, what is the thing I should use for her. Because if she is on high doses of insulin, the Swati madam will give us, you have to add 5% dextrose plus this much of insulin, and with this drip and with the monitoring of the glucose. If she is only GDM and with very low units of insulin, she will say, normal saline plus this much, this much. So we have to take a proper chart, we have to do the proper monitoring, and then only we have to deliver. And lastly, these patients are again very high risk to go in dehydration. And that's why the proper IV fluids should be given to these patients. But again, if she is with associated hypertension, again it's not double-edged, it's a triple-edged sword. Because again it is very dangerous. Because again we cannot go beyond 80 ml per hour. We cannot go beyond that. And so that will be a very... So keep in mind all these neonatal complications, all these maternal complications, and then we have to chart out a plan and then deliver. Nothing will happen. But if we are not ready, all complications will occur. So that we have to keep in mind. Over to you.
You so beautifully summarized for the young obstetricians how we have to be, even however senior you are, how we have to be anticipating the complications, taking help when necessary. It is like, we can't even ignore one point. We have to tell the physician or the endocrine. We have to inform the neonatologist. Now, this is a GDM patient. However well controlled it is, I will need your help today on the day of delivery, and take instructions from them. Yeah, and also the other complications I should not forget, like a preeclampsia or anything else. And then taking help from a senior. Suppose you as you told, maybe shoulder dystocia is one thing. It is a very disastrous thing. You know, the gestational diabetes and the preeclampsia. The problem is if there is a IUD after 39 weeks, or if there is a shoulder dystocia, or if there is a macrosomia with IUD, they are all very pathetic situations where the single doctor, very heroically trying to manage everything on his own, will face a very problematic situation. Also, the medical legal complications of shoulder dystocia is not at all easy. So, in that context, the take home message for all the obstetricians, however senior, junior you are, anticipate, make a list, inform the concerned associated doctors, specialties like the endocrine or the physician or the neonatologist, and take help of your seniors. It's more of a team effort than an individual accomplishment. I feel that was very, very good of you to tell us that, sir. Sir, and also like PPH is more common because of the microsomia and the polyhydramnios. So we need to be doing the active third stage management and keep all the uterotonics ready with us, and and the sugar control. There is Swati, just a quick question for you on the day of delivery. How often should we be checking the sugars? Is it 1 hourly, 2 hourly, or
So
or
as sir has already alluded to this point, somebody who is truly GDM, onset in the second, third trimesters, well managed on diet, or well managed on metformin alone, or well managed on minimal doses of insulin, like less than 20 units requirement, and suppose they had taken breakfast before the labor has started, some meal has been taken, then they generally are not problematic. You just check the sugars 2 hourly, if required 1 hourly sugar monitoring, and they won't require additional insulin. Problem comes when somebody is very much like type 1 diabetic patients, where we can't afford to let them not be on insulin, and when they are fasting, because either way is difficult. We don't want ketosis also. So in those patients, then the glucose insulin infusion along with potassium and monitoring of potassium comes into play. But most of the times, if they are GDM only, then actually at the onset of labor only the sugars start falling down with and we have to expeditiously go down on doses of insulin.
Correct. Perfect. Sir, quick question to you, because you have to exit a little soon for your next engagement. So how do you feel that lactation has got any, is there any difficulty in lactation or lactational failures and depression, postnatal depression, wound infections, they are more common in diabetics?
Yes, wound infections are more common. Again, the lactation failure is again more common. And third thing, even the nipple injuries are very more common. Because yes, that's why probably it is the lactation failure again. I mean, not only centrally, but it is again the nipple injuries are very common in the diabetic women, and that's why, because of the pain reflux and all, yes, this causes a lot of problem. We have to be very careful. I always say that every hospital must have their own antibiotic policy. Though I am doing a clean cut surgery, but because I cannot compare my small clinic with your Bangalore hospital, because the cleanliness and everything that might differ a lot. So every hospital must have their own antibiotic policy in cases of normal patients, non-diabetic patients, as well as diabetic patients. And depending upon that, yes. Another important thing is what we say, the painting and draping, not only during the cesarean section, but during the labor and delivery, that also matters a lot. So here, in every patient, no doubt, universally we have to take a precaution. But whenever my patient is of diabetes, my patient is of anemia, I should give more precaution, because they are at very high risk to develop the hospital infections. So that we have to keep in mind.
Perfect, sir, because you insisted and you stressed upon the painting, draping, and the antibiotic, antisepsis, prophylaxis, even in normal delivery. Sometimes,
Yes.
we just tend to take it casually.
Casually.
However, good we are, so, and we take so much precaution for a section. I think everyone should be aware of the antiseptic methods and antibiotic policies of each hospital is very important. And a quick question on the depression part: do you find that they're more depressed? What is your take on that?
I have seen to be frank, pure diabetic, I have seen less, but diabetes with hypertension, I have seen more. Cause is not known,
Okay.
but yes, they are there.
Yes. Sir, and suppose this patient with a gestational diabetes, PCOS and a gestational diabetes, we have done very good delivery and baby is fine. Then when do you call them back for a sugar? Now, after the delivery, next day will you do sugar, or how long will you monitor the blood sugars after delivery, and when do you call them back?
Right. Usually our policy or the one should have the policy that even within 24 to 48 hours, definitely one sugar level, one CBC and etc. we do. So when everything is fine, no problem. If we see there and one may have to reduce the doses, but in maximum cases, what I have seen in I can say I can quote up to 90% or more cases, suddenly the necessity of the insulin or the anti-diabetics, etc., it drops down. So one should not worry, but at least monitor.
Yes.
Now, patient is only of PCO or GDM, well managed, nothing to worry. After 6 weeks, we have to do GCT. But if the patient who has required the insulin, but GDM, not over DM, probably may not require anything during the postpartum period. But again, post 6 weeks, one must do the GCT. But the patients who are over TDM and they required the insulin, and during the pregnancy, the dose was increased, probably the dose may require but in lower form, or with the help of a physician or a diabetologist, one must change over to the other good over hypoglycemic agents because now pregnancy is over.
Correct. Yeah.
So one thing we have to keep in mind, we can use here other oral hypoglycemic drugs, but with the help of the diabetologist or a physician.
Perfect. So very well summarized. And I think coming to the neonatal complications, Manisha. So how do you handle these babies? How many of them do you think require the NICU? Can you just briefly talk about it?
Yeah. So quickly, I'll just say, despite of all these problems, when it is monitored well, actually, a diabetic woman, 95% of chance that we can have a healthy child if the surveillance is being good. So which are the babies? Not all the babies of the diabetic mothers require NICU admission. So we generally admit to those who are symptomatic. You're symptomatic in terms of respiratory distress or symptomatic because of the hypoglycemia, which is not being corrected with the oral. So giving feed also the child is not, because they are known to have a refractory hypoglycemia. We need to monitor these sugars for about a week or so for them. So any symptomatic neonate who is born out of the infant of a diabetic mother. So we have now, a 38-weeker who is 2.98 kg, but came with the respiratory distress and had a proper RDS. So we had to give surfactant for that baby. So they behave more like preterms than they are only looking mature, but they behave more like preterm. So babies who are also IUGR maybe less than 1.8 kgs because of the maternal vasculopathies, maybe those babies require an ICU admission for monitoring of the sugars. And anybody symptomatic because of hypocalcemia or hypoglycemia or polycythemia, baby looks very plethoric and the sugars are low when the PCV index is more than 65%. So, or the infant of diabetic mothers with the congenital anomalies. Now, as sir said, I am very thankful to you all because because electively antenatal corticosteroids are given for the babies, or electively, because as I can, I myself, as an example, 10 years back, we were seeing so many transient tachypnea of newborns, and that incidence has definitely come down, not only for RDS, with the antenatal corticosteroids, even the wet lungs, the transient tachypnea of newborn is a very common incidence seen in the diabetic babies, so that has significantly come down. So those babies only require this NICU admission. So as for this, these congenital anomalies are more common, but because of the scanning and all, generally the structural anomalies we can detect before. But anybody having this may require a NICU admission. And as I said, only the surfactant and the respiratory distress syndrome is more common in them because of the delayed maturation of the alveolar type 2 cells because of the sugar. So basically sugar, it's a teratogenic for everyone. It delays the maturation for everything.
Yeah, so I think Manisha has beautifully summarized the neonatal care, and actually she has previously told, just to involve her more in the middle of the discussions, I put some questions for her also. So she has summarized how is the childhood and how is the future, and all the cognitive defects these babies can potentially have. Swati, these women who had this gestational diabetes and who are apparently normal after 6 weeks, what are the chances that they developed over to diabetes or type 2 diabetes, and what exactly would be your advice to these women, particularly with PCOS. PCOS itself will increase the chance of diabetes by 16%, impair tolerance by 60%, and almost around by 8% there are diabetes. So how exactly do you advise these women?
So the published numbers can range from anything between 20% to 60% to even 70% of the GDM patients in future will develop type 2 diabetes. But conceptually, we look at it, pregnancy is like for heart, we do a stress test. Like that, pregnancy is a stress test for diabetic status. If one pregnancy patient has developed GDM, then one thing is definitely in next pregnancy, the chances of developing GDM again would be like close to 85% if she has not intermittently lost weight. And if her family is completed, then for her own sake, the risk of developing type 2 diabetes, dyslipidemia, hypertension, and all components of metabolic syndrome is very high. So we take GDM as an opportunity to prime the patients for these lifestyle changes, and they had themselves done it during pregnancy, so they can do it afterwards also. And we place a lot of importance in counseling about lifestyle changes and maybe continuation of metformin.
Yeah, perfect. So in addition to whatever the good lifestyle, I think again, second pregnancy also preconception, she has to make sure that her sugar levels are normal. So I think we have almost covered everything. I would really love to talk to all of you so much. Before I summarize the international 2023 guidelines about gestational diabetes and PCOS, the guidelines say that, all the healthcare professionals like us should be aware that these women are more prone for developing gestational diabetes, and that is a great grade A recommendation, evidence-based guidelines. And also we should be, all the doctors like us should be aware of all the complications which can happen. And then pre-pregnancy lifestyle is very, very important. And then blood pressure also has to be measured. These are the practice points, because as sir told, even they are more prone to develop, apart from diabetes, even hypertension also they can develop. And OGCT, once they become pregnant, OGCT is very important. That is 75-gram glucose challenge test is the test to develop, to check for the gestational diabetes. And we should be aware about all the other different problems during delivery and all that. And as madam told, metformin can be considered in circumstances like to reduce the preterm delivery and excessive gestational weight gain, and in pregnant women with PCOS. And metformin is safe during PCOS. So these are some of the excerpts from the international guidelines 2023 about PCOS and glucose intolerance. So I would love to hear a summary from all the three eminent speakers. I should say I learned a lot from all the three of you today. I'm sure Deepthi will agree with that. So please, can you please summarize or a take-home message to all the doctors, different specialties will be watching with this video, sir?
Right. My suggestion is ki screen all, and very important thing, please keep in mind कि our all patients are at very high risk to develop all metabolic syndromes. On my bag, on my car, and whenever I sit, there is one more big board: eat less, walk more. So that's why I give always everybody, whenever they see my car, whenever they see my bag, and whenever they see me, then I always tell them to eat less and walk more.
Perfect. Madam, sorry, madam.
Sir has summarized everything.
I told you, sir is very, very good. He make it.
Yeah, so that is all that matters, Rest
Yes.
all is our job, doctor's job, to say this is the number, that is the number, and this is the prevalence, and that is the cutoff. But that is what it means.
Correct.
I mean, more
But then
physical
I'm sure
activity.
you would have some message for the obstetricians, because you are an endocrinologist.
Yeah, so
Would you want to give-
from that point of view, I would say that we have to see the patient in whole rather than just the numbers. Family history of diabetes is often very important, often neglected aspect of history taking, and that is the background with which patient is born. And as I said, pregnancy is a stress test. So with that background and with pregnancy, we have to consider that, and gestational weight gain is also very important, that how much weight has already been gained till the time she had seen us. So with that will help us how stricter we would be in further, because gestational weight gain is one of the important factors associated with adverse outcomes. And diet will solve the problems in majority of the patients, and some will require insulin. Don't hesitate to start insulin. And patients are very receptive during pregnancy for insulin therapy, most of them. Those who are not, we can still try metformin in optimum doses. And postpartum care, it is important, because these, for us, these are the captive population. This is the one which we can impress upon the lifestyle changes and make an actual difference in their future life.
Manisha.
Yeah, from my side, generally the parents always want children to be healthy is equivalent to good weight. Okay. So as a pediatrician, we tell that thin is in. Okay. Thin is in for child. If the child is thin and is very active, that's the way to go forward. And if the child, mother has a history of, diabetes or this, we have to follow them up till about age and, about adolescent period. One thing which I always want to tell them, that the incidence of the mother is diabetes, the chance of offspring having the diabetes type 2 is 30%. And if both the parents are diabetic, the child having the incidence is 60%. So when you impress upon them, generally the parents are receptive, because they are also worried if the child gets affected. If type 1 is there, the mother has 1 to 4%, father 10%. If both are type 1, then the child having about 20%. So the numbers are very, very, dangerous and very sinister to hear for. So that one thing, and the thin is in. I think so that is the take home message.
I would like to add one more point to it, that we as children, they will have more risk for developing diabetes if both the parents are diabetic, but they would develop a decade earlier than when their parents had developed it.
Yes.
So that is also a very common observation.
And that's why now, even madam, you are rightly said, because in our paper even we write ki तुझ्या we ask them I say sorry, I said in Marathi. We ask them ki what was the age?
Sir, Marathi.
Yeah. At what age?
Yes.
At what age your father got the diabetes? At what age your mother got the diabetes? So we write off the paper. So we can calculate the risk and we tell them. Even in that history, it is written. If your father has diabetes at the 40, you are. I always say them in a funny manner, you are roaming around that car of diabetes. So if you want to get in, forget me. If you do not want to get in that car, then go to the gym. Simple idea. And one more line I heard recently in a very, very beautiful talk from the Tata Cancer Hospital. There they have a very beautiful study. They compared the non-diabetic patients with the diabetic patients and the cancer outcomes. They are very dangerous, very dangerous. When I forget about the wound and all, even the cancer etiology, even the cancer progression, and sir said sugar is next tobacco.
Oh my God.
So that was a dangerous sentence given by him. Sugar is next tobacco. So I think we have to, I always keep on in my clinic, I have put that board in my clinic. From Tata Cancer Hospital, we have one message, sugar is next tobacco. Kaam khatam. So I think if we do like this, probably, yes, incidence will go down.
Yes, Swati, I think you have to give a punchline, because Manisha has given thin is in, sir is given sugar is next tobacco. So I think you really have to spin out a one-liner.
Madam, I am used to talking a lot, so one-liner is a challenge.
Anyway, it was wonderful talking to all of you. It is such a complicated, common topic, and I myself learned so much, and I really enjoyed. I had to look at the clock to see the timing, and I had to really hurry up. I would have loved to hear more from all the three eminent speakers. Thank you so much. I'm sure it's a very useful and helpful discussion for the young physicians and obstetricians, dietitians, and the pediatricians all alike. Thank you so much for giving your precious time on a weekend. It is Saturday evening. I, from behalf of PCOS Society of India and Durusha ma'am, thank each one of you. I'm sure we'll do much more discussions together. I won't leave all the three of you.
Yes.
So
Thanks a lot for the opportunity.
Thank you, ma'am,
Really enjoyed it.
Yeah, we
In
also
fact, you
really enjoyed. I
conducted
also learned a lot
in a
of
very
things.
great fashion. So
Thank
it
you,
was
sir.
really an enjoying discussion. Thank you, all of you. We would have given more time, but I have to go on the stage to perform a drama.
Very
Okay, all
interesting.
the best.
Very, very
Thank
interesting.
you.
Thank you, sir. Thank you so much.
Thank you very much.
Thanks,
Thank
Swati.
you.
Thanks,
Thank you.
Monisha.
Bye.
Thanks, Dipti, for moderating. You have any closing comments, Dipti?
Yes, ma'am, there are a few questions from the delegates. Just, I think they are actually
If
these
you are in a
questions.
hurry, you please leave the meeting. I will take them. If you are in a hurry because you are going on stage.
Can you please allow me?
Yeah,
Yes.
sure.
Thank you.
Perfect.
Thank you very much, all of
Thank
you.
you, sir. That was a lovely
Thank you,
session.
sir.
Thanks a lot. Thanks a
Thank you,
lot.
sir.
I will take the questions, sir. You please carry on. Thank you so much, sir. Thank you.
Yes.
Yeah,
Ma'am,
Dipti.
moving ahead. Yes, ma'am. Ma'am, these questions I think has been actually covered in the talk, but I think still there are there. I'll just put it on. So one of the delegate has asked, can OGTT be a useful tool for the unmarried PCOS girls? As many times clinically they show all the signs of insulin resistance. Because somewhere sir had mentioned that the insulin test reports of some of the patients are normal. So they want to know whether OGTT can be a useful tool for this unmarried PCOS girls.
Absolutely. See, in PCOS guidelines, all women with PCOS, irrespective of their age, whether they are adolescents or adults, whether they are seeking fertility, not seeking fertility, whether they are lean or obese, all the women have to have a OGCT, that is 75-gram glucose to be given and sugar being measured after 2 hours is a compulsory test as an initial evaluation in all women with PCOS, irrespective of their complaints. If there is an intolerance, we need to do every year. If there is a diabetes, we need to do more often. But then if it is normal and if there is no family history of diabetes and if the patient is not obese, this OGTT has to be repeated once in 2 to 3 years.
Thank you, ma'am. Ma'am, I think the next question is basically on metformin. Metformin started before conception. How long to continue and when to switch on to insulin?
Yeah. Yes, I think, yeah, so I think we did speak about the
Yes.
controversy about metformin. See, suppose now there is a woman with PCOS and she is not diabetic, okay, her sugars are normal. Because she is obese and she is having insulin resistance, we give metformin. For a woman with a normal sugar, apparently normal sugar, we give metformin either to lose weight or to help in conception. And this woman becomes pregnant. So Lancet says don't continue. You do a OGTT. If that is normal, you can temporarily discontinue for first 3 months because metformin given in the first 3 months can have an impact of the childhood obesity after 5 to 6 years of the birth. That is one school of thought. Second school of thought is that, like, now, because we know PCOS is already more prone for gestational diabetes, there is no harm in continuing this metformin in the first 3 months so that she does not get gestational diabetes. But evidence, that is scientific evidence, says that giving metformin in a normoglycemic woman in pregnancy is not going to prevent the development of gestational diabetes. It can prevent preterm labor.
Thank you, ma'am. I think the last question would we mandate giving steroids for every gestational diabetes, even on insulin or on diet management? Is it mandatory at 28 to 32 weeks to give steroid injections, or there's a different school of thought for this?
Yeah, no, definitely not mandatory because as all of us are aware now, with the high sugars, giving a steroid can temporarily push the sugars up. And this, as Swati ma'am told, hyper to hypoglycemia fluctuation is the one which is the common cause of intrauterine fetal death. So in a woman who has got a history of preterm labor, who is setting into a preterm labor, or who we are like in a twins or a multiple pregnancy, we can admit the patient, monitor our sugars regularly, and then give steroids. It is not compulsory or mandatory to give steroids for all women with gestational diabetes to prevent RDS.
That's it, ma'am. I think those were the questions. When only somebody wanted to know how they can visit the webinar, I think they can log in with the delegate registration ID. They can get the webinar even post session also to be seen.
Absolutely.
So thank you all. So moving ahead, I would really like to thank all the delegates, the experts, the moderator, Dr. Chandrika, and the web stream platform USP for providing this, and the PCOS Society of India. Thanks a lot. And here we have on PCOS Connect in a webinar in our website. We have some educational videos on PCOS. We can watch it on the PCOS India site. We can log into it. And we have the next webinar, which is coming on 10 February 2024, same time, same Saturday, PCOS W3 webinar. Thank you all. Thanks a lot. And you can always, if you wish to become a member of the society, please log into www.pcosindia.org. Thank you, ma'am. Thank you, Dr. Chandrika. Thank you, Dr. Swati. And thank you, Dr. Manisha. Thank you all.